Welcome to this deep dive. If you are a resident preparing for your board exams, like the FRCS in plastic surgery, you are in the exact right place. We are jumping straight into a high-yield revision on carpal instability today.
Yeah, absolutely no fluff today. Just the mechanics you actually need to know.
Right. Before we get into it, just a quick reminder to press follow and rate the show if you find this review helpful. And definitely grab a premium subscription.
Oh yeah, the premium feed is essential.
It is. That's specifically where you get access to our journal club and clinical cases deep dives. Those are pure gold for exam prep.
Yeah, you really you need those to see how this theory actually applies in the clinic.
Exactly. So our mission today is simple. We're doing a rapid-fire question and explanation session. We're breaking down ligamentous injuries, kinematics, and the surgical management of the carpus.
It's a massive topic, but, we'll break it down mechanically.
Right, because to understand how the wrist fails, you really have to first understand how it moves. So let's start with normal carpal kinematics. Break down what's happening in the proximal row during, say, radial and ulnar deviation.
Okay, so the main thing to realize is the proximal row is an intercalated segment.
Meaning there are no tendons attaching to it at all, right?
Exactly, none. So its movement is completely dictated by the bones and ligaments around it. It's a passive system. During radial deviation, the scaphoid naturally wants to flex to basically get out of the way of the radial styloid.
Okay, so the scaphoid flexes.
Yeah.
And because of the scapholunate ligament, it drags the lunate with it.
Yes, exactly. It physically pulls the lunate and, by extension, the trichotrum right into flexion with it. They move in synchrony.
Got it. And what about ulnar deviation?
Well, in ulnar deviation, the trichotrum is guided into extension by the hamate. It has this helical articulation.
Right, so the ulnar side extends.
Yeah, the trichotrum extends, and through the lunotrichotrol and scapholunate ligaments, it pulls the lunate and the scaphoid into extension too.
So under normal conditions, everything is perfectly balanced. And that gives us the normal scapholunate angle, right?
Right. On a lateral radiograph, the angle between the scaphoid and lunate should sit between 30 and 60 degrees.
I always like to picture the proximal row as a mechanical linkage system. Like the scaphoid is a gear wanting to flex, and the trichotrum is an opposing gear wanting to extend.
That's a great way to visualize it.
And the lunate is just caught right in the middle, perfectly balanced by these two opposing gears. So for the boards, what happens when those ligaments snap? Let's talk about dizzy and visi deformities.
Sure. Let's start with dizzy. Dorsal intercalated segment instability. This is the big one. It's the most common dissociative pattern you'll see.
So in a dizzy, we're talking about a scapholunate ligament disruption, right?
Yes. The connection between the scaphoid and the lunate is completely gone.
Which means the scaphoid is suddenly untethered from the system.
Exactly. And without that tether, the scaphoid just defaults to its natural tendency, which is to flex volarly.
Okay, so scaphoid flexes, but what happens to the lunate?
Well, the lunate is no longer being pulled into flexion by the scaphoid. It's now only influenced by the trichotrum.
And the trichotrum wants to extend.
Right. So the lunate rotates dorsally. It extends. So you've got a flexed scaphoid and an extended lunate. They're pointing away from each other.
Which means that normal 30 to 60 degree angle just rips wide open.
Yeah, it becomes greater than 60 degrees. That's your classic DZ high.
Okay, so DC is a dorsal tilt of the lunate driven by a scapholunate tear, angle over 60. What about visi, volar intercalated segment instability?
Right, so visi is the second most common pattern. This happens when the lunar trichotral ligament is injured. The ulnar connection is broken.
So the trichotrum extends, but it leaves the lunate behind.
Exactly. The trichotrum goes off and extends, but the lunate is still tethered to the scaphoid.
And the scaphoid naturally wants to flex.
Yes, so the scaphoid remains somewhat normally aligned, maybe a bit extended, but it pulls the lunate into flexion. The lunate rotates volarly.
So they're kind of closing in on each other.
Right, the angle drops to less than 30 degrees.
Okay, that makes perfect sense mechanically. So since dysesthesia, the scapholunate disruption is the most common, let's pivot to how that actually presents in the clinic.
Sure. The history is usually a classic whoosh, a fall on an outstretched hand, or a sudden heavy load.
And they come in complaining of radial-sided wrist pain, right?
Yeah, radial pain, weakness with loading, some edema.
But for the exam, like in an OSE, where exactly are you palpating to find this?
You're looking for point tenderness in the radial snuff box or just distal to Lister's tubercle. That's right over the scapholunate interval.
Got it. And I know examiners absolutely love to test the Watson test, the scaphoid shift test.
Oh, they do. You have to know it inside and out.
And candidates always seem to misinterpret what they're actually feeling. So break down the mechanics for us. What exactly is the examiner doing with their hands?
Okay, so you put your thumb on the volar prominence of the distal pole of the scaphoid, and you apply firm, dorsally directed pressure.
You're pushing it up towards the back of the hand?
Exactly. And while you hold that pressure, you passively arrange the wrist. You start in ulnar deviation and slight extension and sweep it into radial deviation and slight flexion.
Okay, so as you sweep it into radial deviation, the scaphoid wants to flex, but your thumb is blocking it.
Right. In an incompetent ligament, that dorsal push forces the scaphoid to subluxate dorsally. It physically pops out of the scaphoid fossa.
But wait, here's the trap. That pop, that dislocation, isn't the famous clunk, is it?
No, it's not. That is a massive misconception. The subluxation is usually just a quiet, mushy feeling.
So what causes the clunk?
The clunk happens when you release your thumb pressure. Without your thumb blocking it, the tension forces the scaphoid to snap back into its anatomic position.
Oh, wow. So the clunk is the reduction.
Yes, the proximal pole slamming back into the radial fossa, that is the clunk, the reduction, not the dislocation.
That is such a high-yield pearl for the boards. Okay, so clinical exam suggests a tear. The next step is imaging to confirm and stage it. And it's not just a standard X-ray.
No, you need the specific 6-view series. PA, lateral, radial deviation, ulnar deviation, and then clenched fist flexion and extension views.
Let's talk about the static PA film.
Yeah.
Everyone knows the Terry Thomas sign.
Right, named after the comedian with the gap in his teeth. It's a scapholunate gap of greater than 3 millimeters.
But let me warn you, if you're taking your boards, there is a fatal trap here. You see a 4 millimeter gap on an X-ray, you might think it's a positive sign. Why is it an absolute error to diagnose a tear without imaging the other wrist?
Because for some patients, up to 5 millimeters of gap can be totally normal baseline anatomy. It's just natural ligamentous laxity.
Wait, really? Up to 5 millimeters?
Yeah, absolutely. If you don't image the asymptomatic contralateral wrist for comparison, you might end up reconstructing a perfectly normal wrist.
That's a terrifying thought. Always get the comparison view. What about the cortical ring sign? Why does the scaphoid look like a ring?
It's a projectional phenomenon. Because the scaphoid is hyperflexed in a dizzy, you're not looking at it from the side anymore. You're looking at it on end.
Like looking down a tube.
Exactly. The dense cortex of the distal pole appears as a thick ring, and it sits abnormally close to the proximal pole, usually within 7 millimeters.
Okay, but what if the static radiographs are completely normal? I mean, this happens a lot in subacute injuries, right?
All the time. The ligament is torn, but the secondary stabilizers haven't stretched out yet. That's why you need dynamic stress views, like the clenched fist or clenched pencil view.
How does clenching the fist show the tear?
The muscle contraction drives the capitate proximally. It acts like a wedge driving between the scaphoid and lunate, which forces the gap open if the ligament is incompetent.
Makes sense. And if that's still inconclusive, you move to arthrography, checking if contrast passes from the radiocarpal to the midcarpal joint.
Right. But the true gold standard for staging is arthroscopy. That's where you'll get tested on the Geisler grading system.
Right. Examiners love Geisler. Let's walk through it. So you're looking through the radiocarpal space, grade 1.
Grade 1 is mild. You see attenuation or hemorrhage of the ligament. But in the midcarpal space, the alignment is perfect. No step off at all.
Okay, so just some stretching. Grade 2.
Grade 2, you still have hemorrhage, but now you see a slight step off in the midcarpal space. There's a gap, but it's smaller than the width of your arthroscopic probe.
So the probe won't fit through the gap.
Exactly. But in grade 3, the step off is definitive. The gap is wide enough that your probe passes right through from the midcarpal space down between the carpals.
So the joint is objectively unstable at grade 3, which leaves grade 4.
Grade 4 is gross instability. The gap is so massive that a 2.7 millimeter arthroscope can literally drive right through it.
The classic positive drive-through sign.
Yes, you just drive the camera right from the radiocarpal to the midcarpal joint.
Incredible. Okay, so we've staged it. Now we have to talk about surgical algorithms. And timing is everything here, right?
Chronicity completely dictates your treatment. The algorithm branches based on whether it's acute, subacute, or chronic.
So break down those time frames for us.
Acute is under 3 weeks. Subacute is that 3 to 6 week window. And chronic is anything over 6 weeks.
Why does that 6-week mark matter so much biologically? Why can't we just do a simple repair at 8 weeks?
It's all about tissue retraction. In the acute phase, under 3 weeks, the ligament stumps are fresh. You can mobilize them and do a primary repair.
But after 6 weeks,
They've been bathing in synovial fluid for weeks. They retract, fibrose, and degenerate. If you try to pull them together, they just won't heal.
okay, so let's map the treatments. Acute injury, static deformity. What's the gold standard?
Open a repair of the scapholunate interosseous ligament. Sew it back together and pin the bones to protect it while it heals.
Simple enough. What about subacute? The 3 to 6 week window where maybe static films are normal, but stress views show a gap.
Here, depending on tissue quality, you might try conservative rigid splinting or do arthroscopic pinning to let it scar in, or you could do a capsulodesis.
And for chronic, past 6 weeks, fixed deformity. Primary repair is completely off the table.
Right, now you're looking at reconstruction or salvage. Open repair with a capsulodesis, tenodesis, or intercarpal fusions like the scaphocapitate or STT fusion.
And for the boards, you need to know the named reconstructive procedures. Let's start with capsulodesis, specifically the Blatt technique.
Sure, so the Blatt capsulodesis tackles the scaphoid's tendency to flex. You take a flap of the dorsal capsule, leave it attached proximally to the radius, and anchor the distal end into the distal pole of the scaphoid.
So it acts like a tether.
Exactly, it's a check rein. When the scaphoid tries to rotate volarly, this dorsal tether pulls taut and stops it.
But what if the native capsule isn't robust enough? Then you move to a tenodesis. The two big ones are the Talesnik-Lynchide and the Brunelli.
Right, so the Talesnik and Lynchide technique uses half of the ECRL tendon, the extensor carpi radialis longus.
Where are you routing that?
You free it up proximally, route it through drill holes in the scaphoid and trichotrum, and anchor it centrally into the capitate. It creates a sort of sling across the proximal row.
Okay, but the Brunelli takes a totally different approach. It uses the flexor side, right?
Yes, the Brunelli uses half of the FCR, the flexor carpi radialis. You pass the tendon from volar to dorsal, straight through a tunnel in the distal pole of the scaphoid.
Which recreates the oblique vector of the native ligament. But in the classic Brunelli, where does it anchor?
The classic technique pulls it tight and anchors it to the dorsal distal radius.
I've always wondered about that. If we tether the scaphoid directly to the radius, aren't we just destroying normal radiocarpal motion? Like turning a gear into a fixed post?
Yeah, that is a major biomechanical flaw. And that's exactly why the Van den Abele modification exists.
Oh, right. What does the modification do differently?
Instead of anchoring to the static radius, it routes the tendon across the scapholunate interval and anchors directly into the lunate.
So it preserves the motion because it's not tethered to the forearm.
Exactly. Much more physiologic.
Let's shift gears to a totally different technique, thermal shrinkage. This is for early stage, Geisler grade 1 and 2 injuries.
Yeah, using radiofrequency probes. You apply thermal energy directly to the attenuated ligament, which causes the collagen fibers to partially denature and shorten.
But the critical point for the exam is the temperature range, right? It sounds incredibly risky to heat up a ligament inside the joint.
It's a very narrow window, strictly between 70 and 80 degrees Celsius.
And what happens if you overshoot?
If you hit 100 degrees Celsius, you cross into tissue ablation. You'll literally vaporize the ligament you're trying to save.
Wow, definitely a board trap to remember, 70 to 80 degrees. Ugh. Okay, before we leave the radial side, we have to cover RASL Reduction Association scapholunate.
Right, the Rosenwasser technique.
Standard scapholunate fusions have terrible non-union rates, so why do we even use RASL?
Because RASL doesn't actually try to force a rigid bony fusion, it leans into the pseudarthrosis.
It accepts that a bony fusion will fail.
Exactly. You decorticate the faces of the scaphoid and lunate, and then insert a headless compression screw straight across the interval.
The screw with the differential pitch on the ends and the smooth shank in the middle, so it acts like an internal toggle bolt.
Yes. It holds the bones in close proximity, but the smooth shank allows for microscopic rotation. You get the stability of a fibrous scar with the mobility of a pseudarthrosis.
That is brilliant. Okay, so we've covered the radial side extensively. Let's move to the ulnar counterpart lunotriquetral injuries.
Right, the LT ligament. It's a complex C-shaped structure, and when it fails, as we said earlier, you get a visci deformity.
Scapholunate tears are usually just a garden variety fouche, but how exactly does the wrist have to be positioned to isolate and tear the LT ligament?
Well, there are two main ways. First is progressive paralunate instability. The force wraps around the lunate from radial to ulnar.
And the LT tear is the last thing to go before dislocation.
Exactly. Mechanically, this is driven by massive, forceful hyperextension combined with severe ulnar deviation.
And what about an isolated injury, like reverse paralunate instability?
That's a completely different force vector. It's a fall on an outstretched hand and extension, but heavily combined with pronation and radial deviation. The radius drives right into the ulnar carpus.
Okay, so how does an isolated LT tear present clinically compared to a radial-sided injury?
It can be pretty insidious. Symptoms might not peak until weeks later. They'll have ulnar-sided pain, weakness with grip, and they often describe a painful clunk during active radial ulnar deviation.
And for palpation, where's the point of maximal tenderness?
You'll find it directly over the lunotricutural joint space, which is immediately deep to the extensor digiti minimi tendon.
Perfect. So we've dissected the kinematics, the vectors of Disi and Visi, the reduction clunk of the Watson test, the imaging gaps, Geisler grading, and the surgical biology.
It's a lot. But when you synthesize all of this, you really start to see how archaic our diagnostic triggers are.
What do you mean by that?
Well, we wait for a static 3 millimeter gap on an X-ray or a painful clunk to confirm a failure that actually started at a microscopic level weeks or even months prior.
That's a fascinating way to look at it. We're essentially diagnosing the aftermath of an explosion, not the lit fuse.
Exactly. The entire harmony of the wrist relies on such microscopic balance. A few torn collagen fibers can instantly transform the carpus from a fluid machine into a collapsing system that alters the whole arm.
It makes you wonder about the future of biomechanical modeling. Like, imagine AI-driven dynamic ultrasound that doesn't just look for a gap, but analyzes the strain rate of individual collagen bundles in real time.
Oh, theoretically, we could predict which Geisler grade 1 attenuation will inevitably progress to a grade 4 drive-through.
Right, based purely on the patient's kinematic footprint. We could intervene with thermal shrinkage before the gears ever actually uncouple.
Moving from reactive salvage to true prophylactic preservation, that really is the next frontier.
Something for you to ponder as you review these algorithms. To the listener, if this deep dive clarified a complex kinematic concept for you, please leave a comment or a question about the material we covered today down below. It really helps us tailor future content to exactly what you need to crush your boards. Keep studying, stay sharp, and we will see you on the next one.